relief because management, delegation, and priority is super boring, but really important for you to learn, know, understand. For ATI, for HESI, NCLEX, this is a huge portion of the NCLEX is being able to be a manager, is being able to delegate appropriately, and of course, being able to prioritize effectively, which is why today we're doing management, delegation, and priority. So
I put the pro in.
Oh, no,
procrastination.
Yeah, that's not so good. So, all right, so come on in, and you guys can get it interactive as you want to. I'm going to be doing kind of an outline from partly from ATI, partly from HESI, mostly from NCLEX too, so you guys get a good wide range of all the things management, delegation, and priority. Once we kind of get more towards the end, we're going to do some practice questions up on the board. I'm going to teach you how to do priority questions using our patented test-taking priority charts.
Yes.
Which is beautiful, and it's wonderful, and it works 100% of the time. So we're going to be doing that today too, okay? So the first thing we're going to kind of start out with is what management is when we're talking about RNs and we're talking about what that management looks like. So we have different levels of nursing care that we're able to provide. When we're talking about RNs and delegating, there's a whole bunch of really important things that you have to keep in mind for delegation. Okay, when they ask you who are you going to delegate something to, you have to keep in mind you have multiple levels of healthcare, right? So you have the RN, which they're talking about you, okay? So always remember to take responsibility for your patient, not saying you have an RN that. No, I am the RN that does it. There's something that happens to your mind whenever you switch over and you say that I am taking care of a patient rather than reading the question and saying there's an RN that's taking care of the patient. So always put it on yourself, because when you put it on yourself, you look at it through a different lens than if you're just making a judgment call about some RN that's out on the unit. So whenever they ask you who you're going to delegate to, keep in mind you have a team with you, right? So you've got the RNs who are supposed to be the leaders of the team, because the physicians take 482 years to come out there, right? So it's usually you at the bedside. You've got your LVNs, which are awesome support staff, and they can do almost everything that RNs can do, all right? Then we have the UAPs, and the UAPs are there as support staff as well, but there's a different set of things that they can do. When you're choosing who to delegate what to, keep in mind that LVNs can do everything below, like on their level and below. But you don't want to choose an LVN to do something that a UAP could do, because it's a waste of resources. And this is where they'll get you on HESI, ATI, and NCLEX, is that they'll say which of the following would you delegate to the LVN. And you'd pick toileting and transporting and ADLs. Can they do all of those things? Yes, absolutely. Is that the best way to utilize them as a resource? No, because they can pass meds and they can draw labs and they can start IVs and they can do all of those things. So when you're delegating, it's important for you to remember to delegate to the highest level that you're able to delegate to that person. And then that way you're able to delegate appropriate activities to the rest of the team, right? If I've got my LVN doing bed making and bed baths, then who's helping me give medications to my patient? So really important for you to see yourself as the team leader and you're delegating things to the right level, okay? So let's talk about what we can and cannot delegate, okay? So if you're the RN leading the team, when you're delegating to the LVN, the acronym that we use is TAPE, T-A-P-E. Does anybody know what that stands for? Yeah.
We have Pamela with us.
Oh, hey, welcome. Okay. So TAPE, they cannot teach, assess, plan, evaluate. And when we say those things, I'm going to say it one more time. Teach, assess, plan, or evaluate. When you have those things, that means they can't do those for the first time. It doesn't mean they can never do those. You have LVNs that are providing primary care for a lot of different patients on the unit. So if they could never teach, assess, plan, or evaluate, your patients would be in big trouble, right? It means they're not able to do the initial teaching, the initial assessment, the initial planning, and the initial evaluation, which means that they are able to do follow-up teaching. So if there's already been discharge teaching done, then they can do additional follow-up teaching just to kind of fill in the blanks. They cannot do the initial admission assessment or the initial assessment whenever you're coming onto shift. However, they can do all the follow-up assessments. So say the RN comes and does the full head-to-toe assessment at the beginning of the shift, the LVN is able to do all of the follow-up assessments after that, and they have to. That's part of their Nurse Practice Act, is that they have to assess their patient. It's the way that we provide care, right? Anytime that there is a problem, you have to document that there's an intervention and an evaluation. That's our pie charting, right? So in order to maintain compliance with the Nurse Practice Act, whether you're an RVN, it's new, you don't know about it yet. A new,
so exclusive.
It's so exclusive. It's rolling out from Ivy League, the new RVN program. I know. So RN or LVN, regardless of which one that you are, you have to think in terms of pie. So every time you chart that there's a problem, you have to write what you did about it, which is your intervention, and then you have to write your evaluation, or what happened because you did that intervention. That is the basics of all your nursing care. If you do not chart by pie, and you don't have to write it out that way, but if you do not chart and write those and hit those high points, you are not following the Nurse Practice Act, and you could be held very liable, negligent, you could get charged with different things, and we don't want to get charged with different things. So LVNs definitely can do assessments, they just can't do the initial assessment, the admission assessment, the initial things. So that should be documented by the RN, and the LVN is mandated to do all of the follow-up assessments after that. Planning. So doesn't mean that they can't plan at all. It means they can't do the initial plan of care. They can amend a plan of care. They can change it. So let's take, for instance, you have set a goal for the patient to ambulate around the unit 3 times, and the RN wrote that goal, all right? Whenever the LVN took the patient around, they could only make it barely half around the unit. So they can change or amend that plan of care to say, instead of going 3 times around the unit tomorrow, our goal would be sort of a smaller goal. Patient will ambulate around the unit 1 time by noon tomorrow. So they can amend that. They just can't write the initial. And then evaluate. Yes, they can evaluate, but they can't do the initial evaluation. They can do some follow-up evaluations. So let's take for instance, let's say you have a patient that has emphysema, and you're teaching them pursed-lipped breathing. So the RN comes in, she does the initial teaching, shows them how to do that. They do the return demonstration, looks good, all right? Then after that, the LVN can follow up and kind of watch them do the pursed-lipped breathing and reinforce teaching as needed. It's just the initial things that can't be done, okay? All right, so you guys tell me, what are some other things that we are safely able to delegate to LVN? So I want you to list out as many as you can think of, okay?
Would you like a tissue? Do you need some
I don't think it's at that
nose
point.
spray?
Yes. You have it? Oh, I do.
You do.
All right, so I want to hear things that you can delegate to LVNs, things that are safely able. And there's one overriding principle that's most important for anything that you delegate to an LVN. So if you know that, I want you to type that into me too. Should I do this on air? This is the proper way to administer a nasal spray. Most patients tip their head back and do like this.
That is
You can't
wrong.
do that. It will go right down your throat. And this stuff, I don't know if you've
Tastes
ever tried running
terrible.
before. It's awful. The appropriate way, number 1, assess patency.
Oh.
We're going through some struggles, but we're there. Head goes down, inside.
Oh.
Tiny little baby sniff.
Tiny little baby sniff.
All right, Miss Jones, we're about to do the other side. Tiny little baby sniff.
Mm-hmm. You never look
This
prettier.
has been successful, Miss Jones.
No nosebleeds. We're going to evaluate
Epistaxis, yes.
that in another
Problem,
30
I
minutes.
was stuffy. Intervention, nose spray. Evaluate, look for epistaxis, headache, terrible taste in the mouth.
Terrible taste in the mouth. Sometimes.
Newsflash, I can tell you what this evaluation is going to look like. Lord bless us. Okay, so LVN task. All right, so we said we cannot tape for the first time, right? But we can do follow-up tape, so we know that. LVNs, the overriding principle for you to maintain whenever you are delegating is to make sure you are delegating to them a stable patient with predictable outcomes.
Yes.
That means, and I mean, every patient, there's no way we can 100% predict the outcome, okay? However, You know the patients that are going to be predictable with stable outcomes and kind of the ones that are not. If it's a laparoscopic appendectomy of a 35-year-old patient, they're pretty stable. We know exactly kind of what a status post-appy looks like. If it's a 57-year-old who had a left lower lobe lobectomy and they are coming in straight from PACU, they're coming onto the unit, they've got a chest tube, they've got, they had an open incision, they're on multiple titrated drips. I don't know what's going to happen with that patient. They could tank on me, they could bleed out on me. That's not a patient I'm going to delegate. Typically across the board, if it's a patient straight out of surgery, typically that's not a stable patient that is has a very predictable outcome. There are a couple of things, like I said, status post-appy, probably that's okay. Because the biggest things you're looking for are like rigid board like abdomen. I mean, you're looking for bleeding, but most of the time that's a super easy surgery. They're gone and out in 24 hours. If it's anything that you're just not sure what the patient is going to do, that's not something that I want to delegate. You can delegate vital signs to the LVN or to the UAP, but they have to be on a stable patient. You don't want to delegate even things like vital signs on a super unstable patient, because how would you know what to look for, right? How would the UAP know what to report? How would the LVN know what to report? Let's say it's a client that just came back from surgery and they have had a liver biopsy and we're laying that patient on the right side and the blood pressure is just a tad bit low, but it looks pretty good. Most people wouldn't report it, right? But I know if we just had a liver biopsy, our chances of bleeding are high, and I, as an RN, want to catch early on that there is a chance of bleeding so we can catch a bleed early rather than waiting until we have full-out peritonitis. So that's not something I really want to delegate, okay? So you want to make sure that, one, you don't have them tape for the first time. Two, that you are delegating a patient that is stable with predictable outcomes. Okay, so LVNs we want to delegate our patients to that are stable, that have predictable outcomes, and patients that typically are we can anticipate being stable for a period of time. Good choices would be patients that are about to be discharged, patients that have been out of surgery for 3 or 4 days, patients who are not on titrated medicines. There are lots of states where LVNs cannot titrate. So typically our ICU patient should be delegated to the RN or should be an RN assignment, okay? Now let's talk about what they can do, okay? They can pass meds, right? So LVNs can pass meds. Most places they can do IV push. There are very few states who do not let them do that.
Certain meds.
Certain meds. There are, they can do blood transfusions. However, remember that they require a pretty specific set of vitals the first hour. So it would be better to have the RN do the blood transfusions in the first hour because you have to do frequent vitals. Vitals are usually Q15. In that case, we really don't know in any blood transfusion what kind of reaction you're going to have. You could have had 15 blood transfusions come in for number 16 and all of a sudden have a reaction. So even though it is within the scope of practice, it's probably best to delegate that beginning of the blood transfusion to the RN and then have the LVN take over after the the period of instability is over, okay? Anything else we said that LVNs can or cannot do? They can do lots of skills. I mean, they're awesome at skills, probably better than we are. They've had tons of practice on it. So they can do Foleys, and they can do blood sugar checks, and they can start IVs, they can do venipunctures. So the skills portion, they're actually incredibly skilled, and they can do most skills. There's very few that they cannot do. And most of them are things that the RN can't do either. Let's get over. I just can't sit still because I just, I'm so excited about this enthralling content. All right. Mm-hmm. So what kind of things do we want to delegate to the UAP? All right. So UAP, remember, that's our unlicensed assisted personnel. They have a lot of experience on the unit, right? But they don't have a license. So there's very few things that they actually can do with the patients that don't require a license. Best things to delegate to UAP would be ADLs. So the brushing of the hair, helping with brushing teeth, washing hair, bathing, changing linens. Now, they can ambulate patients, but it has to be patients that are stable with predictable outcomes. So if I had a patient that had an MI and this was their first time to ambulate and I wanted to ambulate them once around the unit, chances are probably not going to delegate that to a UAP. That should be something that the RN should be doing the first time because you're going to need to be doing a lot of assessment, okay? Other things you can delegate, they can do some skills, right? They can do like blood sugar checks and things that have QCs, but they do have to be checked off on those first. They can do I's and O's as long as it's a stable patient, all right? They can do vital signs as long as it's a stable patient. Typically, if ATI has your NCLEX are asking you what a UAP which you would delegate, it usually is going to be ADLs, okay? They can feed patients, but you wouldn't want them to feed patients that are on swallow precautions, especially the first time. Because remember, when there's swallow precautions, we have to test for gag reflex or assess for gag reflex, and we have to typically do a swallow study. So if we're doing any kind of assessment, then that really should be delegated to the RN, especially the first time. All right. LVNs can do they can feed patients that are on swallow precautions as long as they've already been fed the first time too. Okay, so it would be okay to delegate. Probably better to delegate to a UAP, so that way the LVN can be freed up to do other things. Okay. All right. Things that the UAP cannot do, they can't start IVs, and be careful when they say things that say like, have the UAP look for. That's assessing. Anything that sounds like assessing, they're trying to trick you and they'll make it sound super therapeutic and nice, but anything that sounds like, hey, I'm assessing, it'll say, have the UAP watch for signs of. That's assessing. So there's nothing that they can't assess. So make sure that you're looking at those different kinds of verbs and seeing if it's just another verb for assessing or teaching or planning or evaluating.
Oh, that's what you did there.
Either. Tape goes all the way down the row, okay? So typically when they're asking you UAP things, it's going to be delegating toileting, grooming, ADLs, bed making, lots of showering things, and then ambulating patients, vital signs, I's and O's are okay. It just needs to really be on stable patients, okay? Because they can do things like watching let me say it in the right way, because you have to choose the correct verb. They can document chest tube drainage, but I wouldn't want to have them document chest tube drainage on a patient that was in the first hour after getting a chest tube or the first 4 hours after getting a chest tube, because that's the most vital time where I know exactly what I'm looking for and what my output has to be, okay? So there's not going to be any clear list anywhere that says this is exactly what to pick for a UAP and this is exactly what to pick for an LVN. This is where you're going to have to just come in and use your common sense and use your management skills in order to say, do I know that this patient is going to have a stable and predictable outcome? Okay, and if I know that, or if I have a pretty strong suspicion, I've seen this so many times before, chances are it's going to be fine, then that's something I can delegate. If not, and I'm like, man, that there could be, this patient may need a chest tube, this patient may have too much chest tube drainage, this patient may not be peeing, they may have urinary tension. If there's anything where you're not sure it's going to be stable or predictable, that is not something to assign to a LVN. Okay? Whew, I said a lot of words really fast. That was a lot
UAP,
of words.
right?
Huh? Or UAP?
Yeah.
What is it?
LVN.
Well, yeah, no, non-stable. You don't want to delegate anybody who's not stable.
Correct.
Yes. Okay. Nailed it.
Ding, ding.
Yeah. All right. So next thing that we're going to do is we're going to talk about some of the management skills that you have to have and some of the management decisions that they will have you make on these exams. Okay. So I want you guys to come in and kind of talk about whenever you are choosing activities, because they will ask these kinds of things a lot. Like, you have these 4 patients. Who are you going to go in and see first? Not only is this a priority, but this is also managing and seeing how well your time could be spent in what room. So you really kind of have to have an idea of how long that activity will take you in order to know which patient you're going to go into first. Okay? And usually they like to put things on the exam like a patient is crying right now because they just got a terminal diagnosis and the whole family is in there weeping. And it makes you feel like, oh my gosh, I have to run in there right now. And yes, they do need emotional support. And yes, I absolutely do understand that. And I'm going to be very, very frank with what is going to be exactly on the exam. If it's not something that they're going to die of immediately, that's not going to be your answer. Do they need emotional support? Yes. Will somebody die if I don't get in there in the next 5 minutes? No. So unfortunately, that's not the first one.
I mean, they could, and that's why they're crying.
I mean, they could, but probably not. If they were crying at this point, they have tears, like, you know. So don't let the pulling of the heartstrings a little bit have you not choose the correct answer. because you're not thinking logically, right? And unfortunately in nursing, we have to make some really ugly choices, and that is one of them. So if it's a emotional response, chances are that's probably not going to be the first room that we're going to go to, okay? So what I'm going to do is I'm going to put some tasks up here on the board, all right? And I want you guys to kind of decide about how long you think that that's going to take you to do in the room. Because when they ask you what's a priority, you have to think, okay, I'm going to need to do this and this and this and this and this, okay? So I'm going to write 4 different patients, and then I'm going to write the different things that those patients would need, and then I'm going to have you guys decide who is the priority, and then how long each of those tasks you think would take, and kind of walk me through. I would go to this room and do this first, and then this room and do this first, and this room and do this, all right? So that way you're able to look at the whole clinical situation, manage, delegate, and prioritize. Okay, so when we turn the camera around, it's going to freeze for just a second, so just bear with us. I'm going to write some things up on the board and let you guys make some decisions here, okay? All right. All right, here we go. I want to see how hard I want it to be. I'm gonna give you the diagnosis too, just because I'm a kind human being. And you need the full clinical picture. Okay. All right. All right, let's say right now it is 07:45. You're probably just wanting to eat breakfast. All the night shifters are still having their breakfast tacos. Getting ready for the day. Okay, so let's see. Let's see what we got for this guy. Okay, Casey's going to read that first one out while I'm writing the other ones.
Diagnosis. CHF exacerbation. 0800 meds. Digoxin, PO. Lasix, IV push. 0900 meds. Lisinopril, IV. Just complained of pink frothy sputum. SpO2 is 93% on room air.
Should have been a sportscaster.
I know. Right? I miss my calling. Well, I guess if nursing doesn't work out, we've got a plan B.
Having plan B sounds good. I'm trying to think of how cruel. Let me think. Okay.
What's the first set? Oh, history. I couldn't make that out. Type 2 diabetes, history of, diagnosis of pneumonia. 0800 meds, IV regular insulin. 0900 meds, IV protonics. Sounds like a dance crew. SpO2 on 2 liters, O2, 96%. Blood sugar is 241.
Y'all have a lot to think about. This is mean. It's mean, but it's gonna work you hard. Okay. Okay.
Diagnosis, MRSA, left leg. Day 3 of admission. Fever 102, white blood cell 21. 0900 meds, vancomycin, needs trough. Speaking of trough, one time we found these two stray cats at work. Their names are Peak and Trough.
At the hospital?
Yeah, we fed them and they said that was unsanitary, so some lady took them home.
And named them Peak and Trough.
Yeah, their names were Peak and Trough.
That's actually kind of cute. Okay.
She kept the names. We got in so much trouble for feeding those cats. Is it time for me to read that one now?
Hold on.
I've already read that one. You're going to add something.
All right, now it's ready.
All right, the vancomycin on patient 3 was started last night. Patient 4, diagnosis, history of COPD, diagnosis of enterocolitis on the inside, complaints of pain, 6 out of 10 in abdomen, had large BM, needs bath and cleaning.
Okay, so here's your assignment. These are 4 complicated patients. Your assignment is to choose, okay, let's do number 1. Who's your priority and what you're going to go and do and what order you're going to do that. 2, if you can delegate anything, I want to hear what you're going to delegate. So each patient needs to have a situation. Like say, I'm going to go see patient 2 first. I'm going to go and do this. I'm going to have the UAP do this. I'm going to do this at this time. I'm going to lump these 2 together or what have you. So you're going to put them in order. You're going to write how you're going to delegate. Okay. And then just kind of write like what your plan of care is as far as what time you're going to go and do each thing. So you're going to have to understand how long it's going to take you to do each thing. Like for instance, if I have to go and take their blood sugar, drop their insulin, like how long is that going to take me? So you need to kind of plan out your morning. So I want a timeline, I want a delegation, I want a priority, give me all the things, manage your morning. Boom, there it is. You have 5 minutes to do this assignment.
Can say what you
This one's
need
hard.
to say.
If there's anything you can't see or read, just let us know. All right, so Jessica, when you say delegate patient 4, tell me what part of it you would delegate and then what part you have to take care of too. So y'all gonna have to basically do like a little plan of care for each patient, because this is pretty much exactly what it's gonna look like when you go onto the unit. You're gonna have these 4 patients. They're all super complicated. They all have different things that they need, and you gotta be able to rattle off, okay, I can do this, 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 and this. I'm gonna delegate this. I'm gonna do this next. So this is what we're kind of trying to teach you to do now. So this is management, delegation, and priority all in one.
Jessica says patient 1 must be dealt with first. And then she says UAP can do baths and cleanup, and that patient is not in immediate danger.
All right, what makes patient 1 so scary?
Ooh.
Pulmonary edema. Boom!
What?
It's like you've been here before. That's exactly what I was looking for. Now what, my dear? Oh, there she is. Pink frothy spoon. She could already like anticipate my question.
Yes, girl.
Nice work, my
Jessica,
friend.
some might say Jessica.
Yes, she did awesome.
Nailed it,
what I was
girl.
looking for. All right, so let's kind of wrap it up and figure out what we're going to do here. All right. So Jessica's telling us that she likes patient 1 to go and see first because this pink frothy sputum is kind of scary. So what do we know about them? We know they have CHF exacerbation. We've got 8 o'clock meds, 9 o'clock meds, and they just complain of pink frothy sputum. We're at 93% on room air. Not horrible, but not my best day, okay? What makes this patient not okay is the pink frothy sputum. Anytime you see pink frothy sputum on ATI, Hesse, NCLEX, I don't care where it is, pink frothy sputum is not normal. That typically means, like my friend said, that we have pulmonary edema. And if this is new onset pulmonary edema, we're drowning in our fluid and we got some problems. So when you're thinking of prioritizing and you're trying to choose your priority, think of what does this patient need that I need to do right away? Well, I need to sit this patient up. They need to be on some oxygen. We need to call the physician because this pink frothy sputum is an indication of worsening heart failure and fluid backing up into the lungs. Now, it's 7:45, so when I go in there to assess my patient, I could do an assessment, I could sit him up, I could put him on oxygen, I could do all that real quick. Go ahead and do his 8 o'clock and 9 o'clock meds if we can go in there right at 8 o'clock because you have an hour, right? So I could do my DIG, I could do my Lasix, I could do my lisinopril, but remember, if you're going to do those meds, okay, you need to check the blood pressure, you're going to have to check their electrolytes. So I would go and run to the MAR real quick, check all my stuff on the MAR, check my last electrolyte levels and make sure those are okay before I give the Lasix. Go ahead and delegate those vital signs, right? So for the vital signs, I would say have the UAP come and do the vitals while I'm in the room. That way, even though it may not be a super stable patient, I'm standing right there and say, what's the blood pressure? What's the heart rate? What's the respiratory rate? Okay, so I'm standing right there and they can do that. So that way they can be doing vitals while I'm checking all the things and getting their stuff hooked up. That Lasix IV push has to be given over at least 2 minutes, right? So I'd probably go ahead and just draw that up with some saline and put it on a pump so I could be doing all these other things while I am helping this patient. He's about to take DIG PO, so I'm going to make sure I've taken my heart rate, and that's good before I give the medicine, right? Then you're about to give Lasix and lisinopril, which can tank my blood pressure.
Oh, Lord.
So you're going to make sure to tell the patient, watch for orthostatic hypotension, change position slowly. So I'm doing a lot in this patient's room, right? All right, but so yes, I agree he does need to be the priority. Let's talk about patient number 2, and just FYI, fun fact across the board, okay? Hyperglycemia will hardly ever kill anybody. If they get severe hyperglycemia, they're probably going to die of DKA first, so they'll go into acidosis. But patients can be hyperglycemic for a long period of time. That hardly ever is your priority on nursing school exams or on the NCLEX.
Hypo, you better run.
Yes, hypo, big deal. Hyper, not so big deal. All right. This patient was diagnosed with pneumonia, all right? So we already know the illness is going to increase our blood sugar. So we already kind of knew that this 241 was coming. Chances are if they have pneumonia, they're probably on steroids too. We're probably pumping them up with that.
They just stressed.
Exactly. They need some IV regular insulin. All right. We also need some protonics. I can shove that on an IV, no big deal. So I would like to lump the 8 o'clock and the 9 o'clock together. But what I can do is, while I'm in with patient 1, and I've already delegated the vital signs, the UAP finishes that, I say, now go to patient number 2 and check their blood sugar and come back and report it to me. She comes back, says blood sugar is 241, right? To say, okay, let me know when the tray arrives, all right? And don't let the patient eat, but let me know when the tray arrives. That's a delegatable task. He's at 2 liters on 96%. I'm happy with that. We're over 95, whatevs, we good. I'm going to wait for the tray to get there anyway. When do trays ever arrive on time?
Never.
Fun fact, never. So I'm not going to give the regular insulin anyway if the tray isn't there, right?
Yep.
So I can wait and get the IV protonics and the regular insulin, and I can give that whenever the tray gets there. So I have a little bit of time on this guy. Respiratory-wise, he's pretty stable. Blood sugar, not terrible. All right. Then we go to patient number 3. He's got MRSA of the left leg. He's on day 3 of admission. Fever 102, white blood cell count of 21. If I just said day 3 of admission, I hate that. I would think that patient is not doing okay. That's why I wrote started last night. Because if we've been on 3 days of vanc and our fever is still 102 with the white blood cell count of 21, we in some dire straits. But if they just started the vanc last night, what probably happened was we did the culture on day 1, finally got the culture back, changed him over to vanc. So what does this patient need? He needs some Tylenol, he needs his vanc, he needs a trough level drawn. This would be a pretty good patient to delegate to the LVN, right? I know exactly what this patient's going to look like. I know why he has white blood cell count high. I know why his fever's high. There's nothing on here that can't be delegated to the LVN, okay? So I'd say, hey, on my patient in room 3, can you go in there and go ahead and draw the trough level, grab your vancomycin IV before you go in there, go ahead and grab your Tylenol or your Motrin before you go in there too, do a set of vitals while you're in there, go ahead and draw the trough, start the vanc for the next hour, and then I'll come back and I'll monitor the patient again an hour after you give that. So I have until 9 o'clock that I have to go back in and take a look at that patient, right? Then we got patient number 4. He has a history of COPD. He's here for a gut infection. Pain never killed anyone. You
Ever.
with me? Amen. All right. Had a large bowel movement, needs bath and cleaning. That's something, yes, absolutely, Jessica's right. I can delegate that to the UAP. Okay? Pain 6 out of 10 in the abdomen. At least we know it's the abdomen. They have enterocolitis. That's kind of like, hey, that's a given. We know that they're going to be in pain. Does this need to be addressed? Yes. Okay? And I will get to that, but it is not the priority right now. So I'm going to be delegating here like crazy. I'm going to be moving from room to room to room in order to get all these patients taken care of. But
Jessica said LPNs can't do IVs. They can, but they have to be checked off to do so.
Yes.
But they can do IVs.
Yes. They can start IVs. They can give drugs via IV, most of them. And so, yes, they can. And so it would be an okay patient to give them that. They can even start the vanc, which would be fine. Remember, vanc has to be given slowly, so they do need a little bit of assessment, but nothing super exciting. As long as you tell them to put the vanc over an hour, then we're good to go. Okay?
They get the red man syndrome.
Huh? They get the red man syndrome. That's what Casey said. Yes, exactly. Okay? All right. So that's kind of how I would plan the morning. That's who we would delegate and how we would delegate. And I think we could get all of these patients taken care of in at least an hour and a half. Remember, too, if you've got some of those 9 o'clock meds, those could always be pushed to 10. So you want to think about that, too, whenever you're doing your management. And think about how long these things are going to take you. Patient number 1, I'm going to be in there for a minute. We got vitals to do. We have a new assessment to do. I've got IV medicines, IV push medicines, PO meds to do. Call the physician. That's going to take me a minute. The patient room 2, all I have to do, if the blood sugar's already been done, all that's been done, I can come in and pop the protonics on the pump, go ahead and put the IV regular insulin on the pump, and go. That one is going to be pretty quick. I shouldn't have a whole lot to do with that. Patient number 3 may take a minute, which is why I would delegate that. And when I say a minute, I mean lots of minutes. Because you're going to have to go in and you're going to have to draw the trough, send it off to the lab, start the vanc. Go ahead, watch the patient, give them the antipyretic. That's going to take a minute. Document all of that. And then you need an assessment again, a repeat assessment within the hour. Patient number 4 shouldn't take me too long. Come in there. If the UAP is already doing the bath and the cleaning and all of that. Now, the only thing you have to keep in mind is that patient's probably not going to feel like being bathed and cleaned if they have pain 6 out of 10 in the abdomen. Okay? So you want to go in and run in there and get the pain medicine. That would also be a good thing to delegate to an LVN if they have the time to do so after finishing patient 3. And that way we can go ahead and get the bath and the cleaning done. Okay? Now, keep in mind on all of these patients, you have to do the initial assessment. So you're going to have to run your line up and run into each of these rooms and do a quick assessment and make sure the patients are pink and breathing and that they don't have any life-threatening urgent needs. But that's how you're going to figure out the delegation, the time management, and that kind of thing. Okay? So, how do you guys feel like you did on that? That was a fun one. That's a lot of stuff.
Common hammer, I nailed it.
What did you say? Oh my gosh. You're not okay. All right, so we're going to flip the camera back around and we're going to talk about some other things. All right, let's do some more delegating things. All right, we understand kind of what our resource management looks like. We understand the beginnings of delegation and what that looks like. Okay. It is part of your responsibility too to do referrals.
All right, everybody.
Okay.
We've been going through some things.
All right, so it's part of your responsibility as the RN to do referrals. Okay. And so referrals, you can make those, and those are able to be made on your own. The doctor will just co-sign on them. That's really not that big of a deal. LVNs can make some referrals, but typically that is more of an RN task. Okay, UAPs cannot make referrals. All right. What do you guys know about the interdisciplinary team? What is your role on the interdisciplinary team, and what are the other team members there? So you'll tell me kind of what you know about that.
You should push right here. I heard that helps.
Here in the middle.
So you push it.
That's feeling so good.
Did you feel anything different?
It sort of hurt where I pushed on it.
Like a waterfall of nasal drainage?
Teaching them all kinds of things today. This is a fun day. All right, so on the interdisciplinary team, we have the physicians, we have nurse practitioner, we have LVNs, we have the UAPs, we have the social workers, PT, OT,
PTs,
pharmacists,
dietitians.
yes. So your role is to be able to help communicate with all these different members of the interdisciplinary team in order to provide the best care for your patient. The person that is the glue that holds all of that together is the social worker or the caseworker. Casey said no, it's me. The social worker is a really good resource because their job is to kind of, it's really the glue that holds everyone together. So their job is to help all of the physicians, the nurses, the LVNs, to help everybody talk to each other and to help with continuity of care. So what happens, especially when we have specialists in the hospitals, that the neurologists only deal with the brain things and the GI people only deal with the stomach things. And so if a patient has a brain thing and a stomach thing and an insurance thing, there's nobody that kind of does all of those things to help them to all talk to each other, okay? Because yes, you can just fix the brain thing, but there's a lot of times where your body, all of our things are working together. And so if we're missing those big portions, that's where the social worker, the caseworker will come in. They also are responsible for helping to make sure that the patient has the medications that they need, that they have insurance coverage, that they have transportation to and from office visits. They will send an entire sheet of where the office visit is, what time it's at, what the address is, who's picking them up. Because remember, Medicare and Medicaid both do provide transportation services for your patients if you call the day in advance. Okay, they're making sure that they're medication compliant, that their home health supplies have been ordered and delivered. So their job is to really look at the whole plan of care for the patient and make sure that they have all the resources that they need in order to thrive once they go home. Because our goal for these patients when they leave is to prevent them from coming back, right? And so the only way for us to prevent them from coming back is to make sure that they have what they need at home in order to be successful, to get healthier and happier, okay? And so in order to do that, we really need somebody from social work to come in and help and to make sure that we get everything together, okay? All right, let's talk a little bit about informed consent because that's a big issue in management and delegation. Tell me what you guys know about informed consent and what the nurse's job is for informed consent, because it gets really specific as far as what the wording is for their responsibilities. So y'all tell me what you know. Oh, I said dietitian too. I did not say dietitian.
I said dietitian. I was reading them off.
I missed it.
This is awkward.
Sorry. You missed it. All right. So this is how tricky they get on the wording on ATI, HESI, and NCLEX. On informed consent, you have to have an informed consent for pretty much any procedure you do on your patient. And it doesn't always necessarily even have to be something super invasive. Even things like ECT involves a consent form. So anything you are doing to the patient that they have a choice to say yay or nay on needs an informed consent, okay? Like things that you don't need an informed consent for would be like IVs, blood sugar draws, like things that are kind of part of the routine plan of care. Anything that the patient is able to say, like, no, I don't really want that, or no, I don't want that happening to me, or that there are risks and benefits and things that you have to discuss, alternative treatments, then they would need an informed consent. It is the doctor's job to get the informed consent signed. It is the nurse's job to make sure that there is a signed copy either in the electronic chart or in the physical chart. It is not the nurse's job to get the informed consent signed. That's the doctor's job.
Jessica said the physician has to explain the procedures. The nurse checks to make sure the patient has given an informed consent.
She's one of ours.
Yes, girl, yes.
She's one of ours. Okay, so if it says, what is your responsibility if the patient doesn't have an informed consent and they're going into surgery in an hour? You would notify the physician and say, this patient does not have an informed consent. The doctor has to come out and explain the risks, the benefits, the possible adverse effects from the surgeries. There's even a place in there for them to write to say, hey, in case this happens in surgery and we have to do this additional procedure, do you give consent for that? The patient has the right to autonomy. They have the right to make their own decisions, so they can say yes, they want to do it, or no, they don't. We just have to say, hey, this is what's going to happen if you choose not to do this. Okay? There cannot be any coercion, so the nurse can witness all of this happening, but you have to witness that the doctor did it in the correct way. He can't have coerced the patient to say, okay, well, you're going to die if you don't get the surgery. Like, that's, is it a possibility? Yes, but that's not a given. So there cannot be any coercion. There can't even be coercion on the family side either. So if you're in there doing the informed consent and the patient is male and he's like, you know what, I'm just not sure about this, and the wife's like, oh, you're doing this, sign this. You have to stop that for a minute and say, you know, he has to sign this. This has to be his decision. It's his body. He has to understand.
His body, his choice.
His body, his choice. Indeed. So he has to understand. Second situation they like for you to encounter is the doctor comes in, does everything by the book, does the informed consent, leaves the room. 20 minutes later, the patient says, what is it that I'm having done today? Oh, that's the phone call that we do not like to make, because you have to call the physician again and say, this patient does not understand what you said. You need to come back out here. And what the physician will try to do is to say, can you just re-explain it to him like I already did it once? But no, that is out of your scope of practice. You'll get it wrong on the exam. You'll get it wrong in life.
In life.
And you don't want to be wrong in life. Because if you are wrong in life on a nursing thing, you will get reported to the Board of Nursing. Here's how this works in management. It's not very fun.
Get ready.
Yeah. So if you get reported to the Board of Nursing, they form a group of your peers. Okay, so they just randomly pick people and say, hey, will you be on this board? Once they pick this group of your peers, then the only criteria that they have for saying, yes, you did the right thing, or no, you did not. Okay, there's not like a very specific rule book that says, if the patient said, I did not want to do this, it doesn't look like that. The only criteria that they have to use is, what would a reasonable and prudent nurse do in this situation? That's their criteria. So they're going to hear the whole situation from beginning to end, look at what you charted, figure out exactly what happened, listen to your testimony, listen to physician testimony, listen to patient testimony. And then their only thing to decide whether you did it right or you didn't is, would I have done the same thing in her position? And that's a very highly subjective place to be, and not a place that you want to be. So you want to make sure, if you feel like, one, the patient was coerced, or two, the doctor didn't explain it correctly, then you need to call the physician back and have them re-explain things while you're in the room. Now, if it's something small, and they like to ask this on the exam too, if it's something small like, what kind of diet do I have to be on after I get out of here? Like, that's okay. You can re-explain that, because it's not something where he's saying he doesn't want to do the procedure. He just needs some clarification on some of the teaching that was done during the informed consent. That's okay to reinforce. But if he is a confused patient, or a patient just sits up and is like, you know what, I'm just really not sure I want to do this, the first thing we would say is, what makes you feel this way, right? Like, always say your therapeutic response first, but chances are you're going to have to call the physician back in and have him re-explain and redo the informed consent if you feel like at all that the patient is not understanding or doesn't want to do the procedure. Do we understand? Mm-hmm. All right. Tell me, what are advanced directives? I want to know what the different types of advanced directives are and what the rules are associated with each of those. Okay. Hint, there are 3. I feel like this is just worse. I can't breathe.
Let me go get you a nutty pot. That would be a fun video to show.
A nutty pot?
Yeah.
I think I would put that on the internet. Okay, give me
Jessica
10
says
seconds. While you
living
guys are
will.
writing down, I want y'all to tell me what are the 3 different types of advance directives and what are they. I'm going to fix this really quick.
You have a nose, Frida?
No, I have peppermint.
I would do that for you. I would.
You would do it for you?
I would. I'd nose Frida you. The Phantom of the Opera is there inside your mind.
That's my daughter's favorite song. She's not even 2 yet. It's the most weirdest thing. She has this obsession with Phantom of the Opera, which is why Casey is
Stuck in my head all the time.
telling us things. Okay. Jessica's not playing today. She's not playing.
Jessica's back hurts from carrying this team.
That's my favorite line from tonight. Get a girl. All right, advanced directives. There are 3. All right, so we've got the living will, we have the durable power of attorney, and then we have the DNR. Yeah?
Mm-hmm. Not dinner. But
Not dinner. Ooh, dinner sounds good.
it's a close one. Yes.
Dinner sounds good. All right. So let's talk about the kind of rules that we have and what your job in managing and delegating these and leading these are. All right. So what is the living will? So the living will is a document that a person signs stating what they want done in the event that they become incapacitated. That living will needs to have a person's name where you are delegating that person to enact your living will. That person is your durable power of attorney. Make sure you choose wisely. Why do I say this, one may ask?
Because you don't want them to unplug your vent to charge their cell phone.
That is true. You also don't want them to leave you on the vent if your wishes are to pull it. So you want to make sure that you choose somebody who is going to enact exactly what you want to happen. Like, for instance, I would never choose my mom as a durable power of attorney. I don't want to be on life support for 822 years. My mother will never pull the plug, okay? My sister would pull it on me if I wasn't even on life support, so I probably...
True. She already pulled the cord.
She already pulled the plug. Boom, boom. So I would probably choose her because I know that she'd be like, no, girl, bye, okay? So make sure that the patient... I'll choose you. You'd probably do the right thing.
I would.
I think you would. She's my cousin, by the way, so that's why. Okay, not like I just chose this random person that I work with to enact my whole life. All right, so that's a durable power of attorney, and they can make decisions. Now, keep in mind, too, they can change their mind on things and go against your wishes, so it is very important that the patient understands that, okay?
True.
So if you have a 94-year-old patient who married a 22-year-old young lady and makes her the power of attorney, and he says, never take me off life support, and she's like, no, he told me one time that he wants him taken off within 30 minutes, we might have to have some questions here. So you make sure you choose the right person. Then we have the DNR, and the DNR orders are weird. All right, so DNR, do not resuscitate, obviously. That means stop life-saving procedures. Now, EMS is not able to enact DNR at home, okay, because what happened probably somewhere along the line was some wife got mad at her husband, he had some kind of heart attack, she just drafted up a document real quick that says, do not resuscitate me, signed Harold Smith the first, okay? Is there a first? Yeah. And then she showed it to him, and then EMS didn't resuscitate, and the poor guy died, and it really wasn't his order. So EMS, because they're not physicians, they are not able to enact DNR orders. So even if they are called out to a home, it is a known DNR patient, they have to resuscitate the patient, bring him into the hospital. The doctor has to put the DNR order in the computer or put it, whatever it is, sign the order in order to enact the DNR, okay? You have to do life-saving procedures until the doctor does that. Now, what you may see in the hospital is that they're like, okay, this is a known DNR patient. He's coming into the hospital. We know he's a DNR, okay? But we have to perform life-saving things in order before the doctor signs the order. We're having a hard time getting hold of the doctor. So you may see them do compressions like...
The heart's not in it. Yeah.
Okay.
Still assessing. Still
life-saving procedures. You may see that in the hospital, but we are required by law to perform life-saving procedures until the doctor's order gets put in. So even if there's a sign on the door, doesn't matter. Even if they produce a living will, doesn't matter. Even if the durable power of attorney is like, do not resuscitate, doesn't matter. Now hold on, because if you are not resuscitating, and then your durable power of attorney says, please do resuscitate, then
you're
what do
in
we
trouble.
do? Then we have to resuscitate. So whoever the durable power of attorney is, if they change their mind, and it is against the living will, we still will do what they ask us to do, because we always are going to err on the side of human life, okay? So if you've chosen a durable power of attorney, you're a known DNR, doctor puts the order in, we've stopped it, and then all of a sudden she's like, no, save her, then we have to save her, okay? So the DNR basically goes out the door, okay? So if
happens a lot in pediatrics.
Happens a lot. And I mean, it just, you don't ever know what people are going to do in that situation, so we're always going to err on the side of life. Now, we've had some people that have gotten resuscitated and then wake up and they're pretty ticked off that they are still alive and got resuscitated. So, but we have to help them to understand, yes, I know you signed a DNR, but remember, this is your durable power of attorney, and if this isn't the person that you want to make decisions for you, this will be a good time for you to change it, okay? Because we have to do what the durable power of attorney asks us to do.
Because people will be suing for everything these days.
Absolutely. Okay. So let's talk about some things that the nurse could do that would be a sign of poor management, poor delegation, and what can happen to you because of that. Okay. And this is why we teach you delegation and prioritization so well, is that you don't make a mistake out on the unit. And those mistakes can end up costing you pretty big. So we talked about what would happen with the board of nursing if you did something that was not right. You can't actually be criminally charged for things. So you could be criminally charged with negligence, and that basically means that you were supposed to do something and you failed to do that thing. Typically, things that we see that we get charged with negligence for, if patients fall because the bed rails weren't up. If there was a whole bunch of stuff on the floor and the patient fell, that could be negligence. So you were supposed to do something and you failed to do that thing, okay? Then there is malpractice. Now, malpractice has become harder and harder to sue for. There's now a cap in most states as far as how much you can sue for, because they were suing people and doctors for everything under the sun. Now, do doctors make mistakes? Absolutely.
Everybody makes mistakes.
Everybody makes mistakes.
Everybody has
Is it
mistakes.
horrible? Yes. Should you get $6 billion because somebody didn't tape your IV correctly? No. So the laws were meant to protect patients and to protect doctors. There are sometimes where this works and sometimes it doesn't. But here's the criteria for malpractice. In order to charge someone with malpractice, you have to show that, one, there was a breach, or there's a duty that you have. So we look at the Nurse Practice Act and say, what was a duty that the nurse had? Two, they breached that duty. So they did something that went against the Nurse Practice Act. Three, and this is the big one that's very difficult to prove and why malpractice cases get so sticky. Three is you have to show that the breach of duty caused harm in your patient. Now, could your patient have had harm? Yes. Is it not going?
No, it's going.
Okay.
Okay.
Could your patient just have had harm? Yes. But you have to find that causality, and you have to be able to prove that what I did caused this bad thing to happen, and it couldn't have just happened by chance. So let's say you have a patient that's on the unit, their status post-MI, and they're on a heparin drip. The patient's PT went up to 98. Patient bled, they went into hypovolemic shock, and the patient has permanent kidney failure and they're in end-stage renal disease. Okay. So in order to say that this was malpractice, I have to say, one, you were supposed to give a certain amount of heparin and we're supposed to be doing bleeding precautions. Two, you either didn't check bleeding precautions, you didn't check the PT, or you gave too much heparin. So even if one of those happened, let's say that the nurse gave too much heparin. Three, they had a bad thing that happened because of that. You have to prove that because the increase in the the increase in the heparin caused the bleeding. So what they'll do is they'll call in 15 other cases where a patient was just on a normal heparin drip, on a normal dose, and they ended up having a really high PT and bled out. But you have to prove that exactly what you did caused that. But if 15 patients had the same outcome and they didn't get too much heparin, can we prove that? So malpractice is a little bit more difficult to prove, but if you do get charged with it, it does get really ugly and you can lose your license, because that means that they proved beyond a shadow of a doubt that what you did caused major harm to your patient. All right, the other thing you could get charged for would be assault, battery, or false imprisonment. Assault means what? I'm threatening that I'm going to do something. If you do not take these pills, I'm going to take out your IV of pain medication. Oh God, that was mean. That came out of nowhere too.
Oh.
I know.
You don't take
Battery.
these pills, I'm putting in a Foley.
Oh, that too.
A rectal tube.
Yeah. Boom. Battery means I actually did physical harm to the patient. And usually assault and battery go hand in hand because you don't typically just walk up to someone and punch them. Like she's like, I'm going to punch you if you don't, and then do. So that's why assault and battery go hand in hand. The third thing is false imprisonment. And this happens because we used improper rules or we improperly used restraints. And so you guys give me, what do you know the rules on restraints are? Are you watching comments so I can see? There's a fly that's buzzing around in
Yep.
comments. Okay, cool. So you'll tell me what are the rules. What do y'all know?
I'll just throw y'all a bone. Like, how often do you need an order? How often do you check people? What are good reasons to use it?
No. We see this a lot in psych. We see it a lot in ICU patients because they're confused. We see it a lot in older clients because they can get dementia, delirium, Alzheimer's. Those kind of things can all cause it. And even just temporary delirium can do it too. So ICU delirium typically happens. They're up all day, up all night. Things are beeping. Vital signs are happening all the time. There's never an amount of restful sleep. And they're ill. So that can cause a delirium and a lot of confusion. So with our restraints, right, you have to prove that you have done every other thing possible before you have restrained the patient. You have to prove that they are going to harm themselves or other people by what they're doing, and that you have tried medications or you have tried, less invasive forms of behavior management before you do the restraints. Once the restraints are on, you want to make sure you tie them to the bed post and not to the rails. Okay, we use a slip knot so we can easily get it off. You want to be able to fit at least 1 finger width in the restraints. You have to do neurovascular checks Q15, all right? So some places will let you wait an hour, but an hour is kind of a long time. So in your hospital protocol, you'll see anywhere from Q15 to an hour, and that is checking to make sure that there are no Ps, right? Which is the pain, the pallor, paresthesia is those. So you want to make sure you're doing those neurovascular checks very frequently to make sure that they have not pulled or it's not so tight that we're losing circulation, okay? You also have to have an order from the physician every 24 hours. You have to have an order within an hour of putting the patient in restraints. Every 4 hours, you need to be checking and making sure that the patient can't come off of restraints, because as soon as we want to get them off, we want to be able to get them out of restraints, okay? If at 4 hours you find that no, they still are a harm to themselves, or what's going on around them, then you have to document that. So we tried to take the restraints off, patient immediately pulled out their NG tube, or patient tried to scratch or harm the nurses, okay? So you have to document that every single time. Every 2 hours, you have to give them the opportunity to toilet, to eat, and to drink something. And even if they decide not to do that, you have to document that you did it, you gave them the opportunity, and that they declined or they refused, okay? So really, really important to know your rules on restraints. If not, you could get charged with some things.
And that is hard. I had a patient once that had the mitts.
Oh, yes.
She grabbed at things and his trach and stuff, and I was feeling bad for him because I felt like we were really connected and like he was going to listen to me. So I took his mitts off and I said, now listen, I'm going to take these off, but if you start pulling at things again, I'm going to have to put them back on.
Yeah.
And then when I went in there later, he had poop all over his hand, tried to smack me with the poop hand, and I was like, I learned my lesson.
When a patient tries to smack you with their poopy hand, I think the relationship is pretty much ruined up to that point.
Pretty
like,
much. We
we're
still
not
worked
doing
on
that
things
good.
afterwards because I'm not a quitter, but there's also chemical restraints.
Tell me what you know about chemical restraints.
They make you feel real good, real sleepy.
The patient or the nurse? Because it can actually be pretty.
Because the answer to your question is yes.
They can
They're
be
not
pretty
screaming.
for both.
I had a psych patient one time. They gave her some haloperidol.
Paradol.
Uh-huh. And yeah, she slept. Everybody was just so relaxed.
Happy and hanging out.
She stopped pulling off her colostomy bag and she just took a little nap. She paraded the hallways with a sheet around her neck like a queen, and she'd wave at all of her people. And then she'd try to fight people.
There you have it.
Then she took a nap.
It had to happen.
Chemical restraints.
Chemical restraints. It's always helpful.
She never saw it coming.
You'll see those shirts that say like Haldol, PRN, our best friend, things like that. All right, so I think that next what we want to do is to go over some prioritization and how to do priority questions. Students typically tend to struggle with this pretty hardcore. So I'm going to teach you a way that we do priority. It's our priority chart here. It works for almost every question that you have that's priority. And that could be anything from, they'll literally ask, what is the priority for the nurse? Or it'll say, what do you do first? Or what's the most important? It works in all of those situations. It will not fail you. Are you with me? Okay, so we are going to turn on the camera and then we're going to start working on prioritization. So I'm going to show you what the priority chart looks like, and then I'm going to let you guys do some practice questions and practice the priority chart. Okay? Let's hit it. Boom. Boom. All right, let me erase this.
My body tells me no, but I won't quit because I want to know.
So you'll see different educational avenues do different things. There's a decision tree, there's a decision pathway, there's a clinical pathway. There's all different kinds of ways that you can come about to getting the answer. A lot of those we found are really complicated or kind of frustrating. And so what we did was we come up with a really simple and easy way to do priority questions that will not fail. Okay, and it's easy as this. This is your little chart here. Here, you're going to say, what is the worst case scenario, okay? The worst case scenario that would happen with my patient if I did this or I didn't do this. Will it kill my patient? And this is just a yes or no. I do a check or an X, and that's it. This last one over here is how fast. Now, when you're doing how fast will it kill your patient, you're not going to know exactly. You can do in just kind of generic. So that would be anywhere from seconds, minutes, hours, days, weeks, months, years, okay? And so whatever one is going to kill your patient the fastest, that is your priority, okay? Mm-hmm. So let's do a quick practice question, and we're going to kind of do it together. Let me make one up off the top of my head. All right. Let's say, okay, let me do this one.
Didn't see that coming.
Dum dum dum. And I'll read these out to you because I'm getting, as I go down further, I'm getting your writing smaller and smaller. Let me write it this way.
I can almost touch my arm.
That's great.
Chicken wing.
So we're going to do one that's kind of simple so we can work through it together. And then once I give you guys your own, I'm going to kill you with the answers.
Oh.
All right, here we go. Okay, so you have a nurse is caring for a client with a history of COPD, type 2 diabetes, and hypercholesterolemia. What would she do first? All right. So whenever we're doing test taking, you always want to look at the question first and kind of understand what the question's asking. So this patient has a lot of stuff going on. So instead of saying a nurse is caring, you say I'm taking care of. So I'm caring for a client who has a history of COPD. So I already know we're going to have respiratory issues, extra mucus, tripoding, we're going to have all those things. Type 2 diabetes. Well, I know that if they're sick, things are going on, they're going to have increased blood sugar, We may have some perfusion issues in the legs. You know, I'm kind of walking through and thinking of all the different things that I can anticipate happening. They have hypercholesterolemia, risk for atherosclerosis, risk for an MI. So all of these things are kind of running through my mind. So when I'm doing my priority chart and what I'm going to do first, then I'm going to think, what's the worst case scenario if I don't do this thing? So what would be the worst case scenario if I did not sit the patient upright and administer 2 liters of O2? Worst case scenario would be the patient would get hypoxia, right?
Yes.
Okay. Will this kill my patient,
Yes.
or could it kill my patient? How fast would it take hypoxia to kill your patient? And you got to think with hypoxia, people think it's really fast. It isn't.
I was about to say days.
It's not even day. Well, maybe with COPD it's a
I'm like,
possibility. I don't know. With COPD, it can be a little bit weird. But the fact that if I don't give him any O2 and he's here for an exacerbation of COPD, I mean, it would probably take like hours maybe before
that
he
what
would
he's here
completely
for?
die. Yes, I wrote exacerbation right here.
Oh, oof.
You didn't see it. All right. Take blood sugar and administer insulin. All right, what's worst case scenario if I don't do that? Hyperglycemia.
Hyperglycemia.
Now, we've already talked about how we feel about hyperglycemia.
It will
Will it kill your
eventually
patient?
kill you.
Yes. How long does that take? A
Weeks.
while. At least weeks. Okay.
Unless you're a type 1 kid, 3 days.
Yep, I agree. Administer simvastatin at hour of sleep. Worst case scenario, the patient continues to get high cholesterol.
Yes.
Will they die from this?
No.
Could. They would have walked through this with me. They'd have to get high cholesterol that led to atherosclerosis. That atherosclerosis would then have to lead to an MI. The MI would have to be severe enough to kill. I mean, people can have high cholesterol for months to years.
I live
say
with that.
years. Oh,
Let's say
bless
lots
you.
of years.
Let's start a GoFundMe.
Let's do that. And if
D,
it's over
implement-
250, I can't get dessert.
Exactly. Oh, we've done that before. She won. Implement a low-fat diet. All right, what's a worst-case scenario if I don't implement a low-fat diet?
Obesity.
Still, we're
Fatness.
going to have increased cholesterol, right? Because that's basically what we're doing it for. Now, fun fact for test taking, if there are 2 things that are too close to being the same,
Then it's
they're
out.
always going to be both wrong.
Yes.
Because will this kill my patient? Yes. How long will this take years? This is asking basically the same thing. So these would be wrong. So if I'm looking for the one that's going to kill my patient the fastest,
Hypoxia.
then you're going to do this first.
Ding, ding,
Now,
ding.
ABCs are not always going to be first. There may be some situations where they are not. So don't fall back on ABCs all the time. Use your priority chart. Because remember, we said with hypoxia, like you've heard of stories where patients have fallen into a pool and 15 minutes later somebody brings them out, resuscitates them, and they still live. So you can go a pretty good period of time being hypoxic, okay? There are other things that can kill you much faster than hypoxia.
Like a gunshot wound to the abdomen.
There you go. Or maybe the heart.
Perhaps
maybe a guillotine. That's faster.
Yes.
So don't rely just on ABCs in order to get you through. You really need to step back and think and critically think and decide what's going to be the fastest and kill you. So let's give you an actually hard question because this one was super easy.
So easy.
So easy. Well, I was just kind of
Oh
showing
my
you how to do
goodness.
it. I'm going to give you a question and we're going to let you work through and use the priority chart and figure it out. Okay? So you want to think worst case scenario, will it kill my patient? If it will kill my patient, how fast? Now, if you get to the point and it says it will not kill my patient, then you just end it there. Because if it's not life-threatening, it's not your first thing to do.
If it won't kill you, then how can you put how long will it kill you? Will it take to
You
kill
can't.
Exactly.
Exactly.
It would be
I
foolish to
feel
try.
like it's important for us to just mention. Some people will spend some time trying to figure it out.
Less than 5,000
All right, so
times.
let's do one that's just hard. Okay. All right, so nurse is caring for 4 patients. Which will she see first?
Which one?
How hard should I make it? Because I have so many.
Very hard.
Okay.
That's what she said.
Here we go. Okay. Can you see that right now? Let me-
No.
My pink is getting kind of weak because it's so much else. Okay.
Oh.
Okay.
Oh yeah. You can see that real good.
We got, can you? Okay.
49-year-old male client with
92.
or 92.
Oh my God.
I can't see very
Maybe
well.
you can't see it very good.
With new onset.
Don't read it yet, because what if I have to change something? Sometimes I get excited and I have to change it. Let's see.
Oh.
Okay.
Okay.
Good
Okay.
about that one.
All right.
Okay.
Jessica said guillotine. That's a bad day. That is a bad day. It's a throwback Thursday kind of day.
You're just gonna lay back and relax. Enjoy yourself.
Treat yourself. I need to massage my back so I'm not twisted.
I'm excited to see what happens when I get it done. Let's see.
Petechia. I like that word.
I do too, but I never can remember how to spell it, so I was trying to nail it.
Petechia. Jessica said A is perhaps a UTI.
I don't know, is it?
Perhaps.
Okay, this is hard. So I'm going to give you guys a few minutes. This one's tough. So you're going to do the priority chart. I want you to think of all the possible things that could be going on. So you have a 92-year-old male client with a new onset confusion. I'm going to move it a little bit closer so you can see. Temp 102, white blood cell count 22. You've got a 2-month-old female client with a temperature of 101.3, irritability, petechiae rash on the torso. C, you have a 48-year-old female with abdominal pain, 8 out of 10, intermittent nausea, moderate vomiting, potassium level 3.4, and then D, you have a 12-year-old male client with severe sore throat, fever 101, fine sandpaper-like rash, and a new onset murmur. This one's tough. I'm going to give you guys a few minutes to write out your priority chart. I would like rationales for every single one. I want a rationale and put them in order. So what order you would see them in, and with a rationale. Like, I think this patient has this, so I would do this. I want the full, like, you're about to graduate nursing thing. Give it all.
Jessica said D is rheumatic fever from strep, right?
Ooh, I don't know. Is she right?
Is it? Tell us all the things. need y'all's priority. Who's going to die first?
All right, here we go. You ready?
I'm ready.
Ready or not, here we come. All right. So you got 4 patients. If we're going to do this as a priority chart, okay, let's look at number 1. 92-year-old male client, new onset confusion, temp 102, white blood cell 22. Now, if they give you an age on the patient, chances are it is for a reason, okay? Now, this is a 92-year-old client, so we know that it's an elderly client. When they get new onset confusion with signs of infection, Jessica was right, chances are it is a UTI. So what is the worst case scenario of this patient? Well,
sepsis.
Yes, so sepsis. So could that kill my patient?
Absolutely.
Yes. Let me write like a little chart
Write a
here.
mini one right there on the
Yeah,
side.
I'll just put like a little one up here.
Oh, perfect spot.
Yes. Okay. Well, sort of perfect.
Oh.
Okay.
Oh.
I don't know. I just thought I'd make it like a little bit bigger. Okay.
There we go.
So, 1, 2, 3, 4. All right. So worst case scenario for A would be sepsis. Can that kill my patient?
Absolutely.
Absolutely. How long would that take? Probably a couple days before we would go into full septic shock and actually die from sepsis. B, a 2-month-old female client, temperature 101.3, irritability, petechiae rash on the torso. What does a petechiae rash mean? Hint, not good. It's a little bitty baby. We have a high temp, irritability in a baby, never okay. Petechiae rash on the torso, that's not good. Okay, what does this baby probably have? Those are the signs and symptoms of meningitis. So worst case scenario is not even meningitis. Worst case scenario would be sepsis for this baby too. Okay, now but sepsis in this baby with the meningitis, they're gonna die way faster than an adult with a UTI.
Truth.
Because this is basically eating their brain away, right? So we're looking at this baby could die within hours, right? Yes. And the other thing you have to think of too, who I see first, if this patient just came in, then they need to go on precaution. So that's going to be a pretty immediate thing. So I need to keep that in the back of my mind.
Yes, Lord.
48-year-old female with abdominal pain 8 out of 10.
Whoa.
I don't like that. That's bad. Intermittent nausea. Intermittent is an adjective. Please keep in mind your adjectives when you're doing test taking, okay? English is hard, and they're trying to, those are your describing words. They're trying to help to get you somewhere. Intermittent nausea, you're saying you have nausea that kind of comes and goes. I ain't worried about you. Moderate vomiting. Did it say severe?
No.
No, it said moderate. Potassium level, teeny bit low, and I'm talking like 0.1 low. We are right. So this patient, if I had to guess, she's 40, female. So if we're starting to like kind of see
fat,
that is not kind. She may be curvy. It's sounding like the start of the 4 Fs, and the 4 Fs typically mean gallbladder disease, right? Mm-hmm. Now, what do we need to treat? We probably need to give her some IV fluids. We need to watch her electrolytes. You know, we need to treat the pain. But what's the worst case scenario of this patient, just given what we know? Well, we know that pain doesn't kill anyone, so I wouldn't put that as the worst case scenario. Probably dehydration would probably be worse.
Electrolyte imbalances.
Or electrolyte. So even dehydration or hypokalemia. Now, hypokalemia almost always is going to take some kind of priority, but this one is very, very mild, like very mild. And she only has moderate vomiting. I don't see this getting a whole lot worse very, very quickly. So I would say probably dehydration would probably be your deal. Will that kill my patient? Yes. How long would it take for dehydration to kill your patient? Meaning you get dehydrated, you go into super hypovolemic shock, and then
a long
you die.
Time.
I mean, a couple of days before you would really be in hypovolemic shock. 12-year-old male client with severe sore throat, fever 101, fine sandpaper-like rash, and new onset murmur. Now, yes, just you nailed it, which I was really not surprised that you nailed it, but just surprised that somebody got that because it's a hard presentation. But yes, this does look a lot like rheumatic fever. Now, rheumatic fever is where the bacteria goes. It vegetates around the valves. It causes an infective endocarditis. So really, what is worst case scenario? They would still die from an endocarditis or a sepsis from endocarditis. But you got to think, this sepsis would have to, okay, so it's going into the heart. We have a new onset murmur, so it's just started. All of the bacteria would have to vegetate around the valves, and your blood would have to pick that up. I mean, we're looking at a couple of days, if not more, before that would actually cause a big problem. So if you look at these 3 of them are sepsis, but using our critical thinking skills, we know and can foresee and look ahead and see, hey, this is how this presentation is going to run. So the fastest would be our baby here, who most likely has meningitis, who needs to be on precautions first anyway. And that's a little bitty baby with a brain infection. That's going to happen a lot faster than any of these other infections would happen.
And Jessica, you're not reading too much into the abdominal pain. I don't hate your answer.
What'd she say?
But because she said that she wants to know what's causing the abdominal pain. If she has a ruptured appendix or peritonitis brewing, that could be super bad.
Yes.
Which it could.
It could, but if it was truly peritonitis, then they would tell you on there rigid board-like abdomen. Don't assume something that severe without getting it. Do we want to do more information on her? Absolutely.
Yes.
But given the presentation we're given right now, I don't see anything that's red flagging me.
And you have to watch the age and everything that they give you too.
Absolutely. And 48, she all right, you know. All right, so let's try another hard one, shall we?
We shall. I'm having the time of my life.
I know, these are really fun. Okay.
My business card holder fell out of my pocket. Oh, look, it came in the mail.
All right. Okay. You want another 4-patient one? Because those are really fun.
Yes.
Okay. Let's see then. See what I can come up with.
She said, oh snap, I haven't had peds yet. Yes, meningitis
Oh,
prevails, yo.
better watch it. Here it comes.
Hey,
I'll do this. Okay.
Oh.
Okay. Let me channel my inner question writer. Okay.
It's coming, it's coming.
Mm-hmm. Okay.
You're about to see gold, everybody.
You know it. Okay.
Whenever I see CRP, I'm always like, crap, that's not good.
I see what you did there.
Babinski.
You like that word?
I do. I do like that word.
Oh, I know. Okay, this is a good one.
Okay.
I'm happy with my choice. All right, so I want you guys to look through these. Okay, I want you to do the priority chart. Be prepared to give your rationale for why you chose and why you did not choose.
You're feeling the abdomen on this question.
This one's hard.
Mm-hmm.
After this, we're going to do a skeletal play.
Oh my
That's gonna be very
word.
fun. I get sister. I have problems.
I just had to get comfortable.
Put some recliners up in here.
Yes. I gotta buy one of those after I buy them a bed from my office to sleep on. You know what I need in my life right now? Ice cream.
Cupcakes. Oh, I was gonna say
so
pizza.
yeah, always. I feel like the Ninja Turtles had the right idea.
Pizza sounds really good.
Huh?
Pizza sounds really good.
I know.
Actually, everything sounds really good right now.
I should have so late. I've ordered some Pizza King. I know you love that place.
I really do.
I do too. Had time
I knew if I got quiet for long enough, you
and I
would
never felt this way before. Yes, I swear it's the truth.
It is the truth.
And I owe it all to you. That was a remix.
It's good. I've had 2 cups of cakes today and a big giant piece of fudge.
Oh, I haven't had enough.
And I ate canes twice.
I love Canada.
Oh my gosh.
I feel like we need places.
Stress eating. Lord Jesus, help us with stress eating.
Or don't. I love it.
All right, here we go. Y'all ready? Let's do this thing. Okay. Hello, priority chart.
Hello there.
You sound like Mr. Rogers or something. Why are you the way you are? Okay.
It's a
All right.
blessing and a curse.
Right? Okay. Here we go.
Whoa, okay.
What's wrong? You don't like the way I read the chart?
No, I do. I just, the comments on here,
Mm-hmm.
like Jessica put a bunch and I missed some of them.
Oh, okay. All right. So here's what we know. We're going to do worst case scenario, will it kill my patient, and then how fast. 22-year-old female with history of severe abdominal pain, ESR and CRP are elevated, positive hemocold.
She said could have a GI bleed or colon cancer.
They could. So worst case scenario here, we know they have severe abdominal pain. ESR and CRP are elevated, which means that we have an inflammatory condition. We do have blood in the stool. Now, keep in mind, whenever they give you an age and a sex of the patient, it's for a reason. There shows me no indication for a 22-year-old female with no other previous history that she has a GI bleed. Now, it looks like she possibly could, but let's decode this a little bit more. Now, if I just saw this, a severe abdominal pain, ESR, CRP, elevated, positive hemocold, yeah, I would be like, okay, maybe it's a bleed. They don't give me hemoglobin and hematocrit. So if they wanted you to believe it was a bleed, that would have been there, right? All it says is we have positive hemocold. Probably all of us have positive hemocolds today. I mean, did you eat red meat? Did you not, right? But they gave you a 22-year-old female. Now, what do I know about young ladies in inflammatory conditions? Oh, this got weird. Anytime you have age and sex of the patient, keep it in mind because they're doing it for a reason. So if I have a young female with an inflammatory condition with these things, chances are
Crohn's.
she probably got the Crohn's.
The
okay?
Crohn's.
So just going off what I'm seeing right
Get
here.
a girl
Yeah.
Crohn's.
Just if I'm going off what I'm seeing here, all I see is that there's some blood in the stool. We have abdominal pain. ESR and CRP are elevated. We're having this huge inflammatory response. She's hurting. So worst case scenario, really, I don't see one here. Now, I guess the worst thing we do is say, like, maybe she could get, like, a severe GI bleed or a worsening GI bleed. That would be the best we can do given what we have. Now, we know Crohn's patients can have electrolyte imbalances, and they can have dehydration and diarrhea, but it doesn't say diarrhea on here, so don't read more into it than you're seeing. So the only thing that I see that could kill my patient would be a GI bleed. Could that kill them? Yes. How long would that take for a patient with Crohn's to have such severe bleeding that they die of a bleed? I mean, that would take weeks, right?
Forever.
A long time. 4-month-old with a positive Babinski. What is a Babinski sign? We know it's a response where you stroke the bottom of the foot, the big toe dorsiflexes, the rest of the toes fan. Okay?
Yep.
Now, I know in adults a Babinski is not good because it's a primitive reflex that they're now showing. So I know that patients, like even if you haven't had peds, I know just you haven't had peds, but...
Well, she said 4-month-old with Babinski's is normal, right?
Go away so if I know,
yes, Jessica.
So if I know that this is a primitive reflex for an adult, well, who better to have a primitive reflex than a brand new primitive baby?
Who better?
So this is actually normal. So there is no worst case scenario. My patient will not die and this is fine. Okay, so this is out and this is out really. Probably. 32-year-old female client, left lower quadrant abdominal pain, shoulder pain, nausea.
She said, like ulcerative colitis?
With shoulder pain?
No.
I know, it's weird.
Well,
so
with
don't
women,
leave
it
any
just
of these
throws
out.
everything.
I know I have a 32-year-old.
Yes,
She's
you do.
female, so this is a
Yes,
young
she is.
lady. Left lower quadrant. What's in the left lower quadrant? It's either going to be some kind of colon or something reproductive, right?
Oh.
So if I have unilateral pain with referred shoulder pain, now what our brains like to do whenever we can't put all the pieces together is we like to ignore pieces that we can't fit in the puzzle. But what would happen if you put a whole puzzle together and the cat is missing its paw?
Oh.
I know. So we have to put all the pieces together. So she's a young lady.
Yes.
She's got left lower quadrant abdominal
She
pain.
sure does.
I don't see anything in here that tells me there's something wrong with her colon. Do you? Nausea is typically something upper if it's going to be something gut, right? So I don't really see that. I know she's young, so if the only other thing that's in the left lower quadrant is something reproductive, could it be?
Could it be?
Where does the shoulder pain come in? Fun fact for all of nursing school. Anytime they say referred shoulder pain or any shoulder pain when it has nothing to do with that, that's considered referred. That's a red flag, okay? Shoulder pain, referred shoulder pain is always a sign of something ugly. Always. Left. This is my right side. God bless me. Shoulder pain in women that are having jaw pain and breast pain, that's a sign of an MI.
Yep.
Patients that are having right upper quadrant pain with severe nausea and vomiting with shoulder pain, that's a gallbladder disease, okay? This patient, since I know it's got to be something reproductive, we have nausea associated with it and shoulder pain. Well, what could be happening in my left lower quadrant reproductively that could be causing a problem because it's just on one side. So it can't be something that's in the uterus because you only got one uterus and it's in the middle. So what goes out to the sides would be fallopian tube. So what would be in my tube that would be causing severe left lower quadrant abdominal pain? She got a tubal. Okay.
Tubal.
This is a tubal pregnancy, right? What's the worst case scenario?
Ectopic
We have a
pregnancy,
ruptured ectopic pregnancy. That would cause hypovolemic shock, right?
Yes.
Because she's going to bleed out.
She sure is.
Can that kill my patient?
Yes.
How quickly?
Pretty quickly.
Minutes. Next one. 62-year-old male client with a pulsating abdominal mass.
Oh.
That sounds horrible.
Terrible.
And I would say probably 70% of people will just pick this because they're like, pulsating abdominal mass.
Pulsating.
Dear God.
My word.
Okay, so what do we think? If it's pulsating, it's got to be something arterial.
It's gotta be.
What's arterial in my abdomen?
What could it be?
My abdominal aorta?
Oh.
Maybe we have a...
Aortic aneurysm.
Now, will the aneurysm kill my patient? Will the rupture kill them?
Yes.
Now, some people will walk around with a pulsating abdominal mass for years before we rupture.
True.
So worst case scenario, he could end up having a rupture, but we're not there yet. So could this just mass kill my patient? No. Could the rupture kill them? Yes. How long would that take? Probably minutes. Okay. But we're not there yet. So if we're looking at an actual versus a risk, boom, there it is. Boom, there it is.
C's get degrees.
There it is.
Yes.
All right. So that's how to do the priorities. Okay? If you use the priority charts, it will never go wrong for you. Okay, you just have to learn how to use it appropriately. Okie dokie?
Yes.
All right. Next, let's do a select all and apply, and I kind of want to show you a quick and easy way to do select all and apply. Now, you've probably heard all the things that people have said before, and it really does work when you're doing select all and apply to just say, is this true, is this false, and use each one independently of each other. Where people typically go wrong with select all that apply is they're like, okay, well, I had 2 this time, so there's probably going to be 3 next time, and then, wait, I had 3, so there's either going to be 2 or there's going to be 4. They don't care. It gets randomly picked.
I ain't worried about that.
They're not worried about that. So stop worrying about what you chose before and what you didn't choose before, and like, how many can I choose, and I know it has to be at least 3. No, it doesn't. It doesn't have to be anything.
Let me just tell you something about select all and apply.
Oh, you tell it.
Let me tell you what I hate.
Okay.
Is when I'm like, it's either hyper, like for instance, it's either hyperthyroidism or hypothyroidism. I'm going to use the choices to decide. And half of them are hypothyroidism and half of them are hyper.
That's exactly how they do it.
That doesn't help me at all.
This is exactly how they do it. And so most times, even if you don't have lists of symptoms, most times it's going to look like this. And how you do select all that apply, if you really don't know the content, you can always divide it out into 2 sides. And they're typically going to have things that go onto both. So this will say, and it doesn't matter what the question is. Did y'all know that? Oh my God. When you don't know exactly what the content is, you can just kind of skip past the question. But if you know the content, then always go with content before you go with test taking. This is a way to do select all that apply by test taking. Okay? Are you with me?
Yep.
Okay.
Here we are.
Here we are. Okay, so if I just look at these and I have no idea what the question is, we can kind of start to loop them sort of where they go. Tachycardia and hypotension almost always go together, right? You get hypotensive, you're going to get tachycardia with it. So there's probably these are going to go together. So this is going to go on this one side here. Warm skin, tachypnea, bradycardia. Well, you have bradycardia and tachycardia. If you have 2 opposites, only one of them can be correct, right? Mm-hmm. So you're going to put bradycardia on this other side. Okay. You've got hypotension and tachycardia over here. Now, if I have hypotension and tachycardia, typically things are happening that shouldn't be happening. Warm skin means that something exciting is happening. Tachypnea means something exciting is happening, right?
Yep.
So I would probably put warm skin here. Everything's hot and moving, and you've got tachypnea, and everything's kind of going crazy because of what's going on here. So the only one that's kind of odd man out is the bradycardia. Therefore, if I was just to do this just by test taking, I would pick this. And I would be right because I wrote the question. However, I know to divide it out in my 2. So what if I put the question, what all are the signs and symptoms of DKA? Boom, there it is.
What?
Okay? And you can do this with almost anything. Let's try another one that's not just symptoms, okay? Because they like to loop things into 1 and 2. So you kind of have to be able to pick out and see what goes where, okay?
That was my biggest problem. I could separate them into groups, but I'm like,
which one is it? Exactly. Then you have to go back and look at the question and see if the question will give you any clues. Okay? All right, let's see what I want to do here. So this one's kind of fun, and I just wrote it, and it's just fun. Okay, so let's say I don't even give you a question. Let's say you get a question on the exam that says, your patient has received a diagnosis of Mgmt disease.
And you're like,
like, excuse me, what? I studied for days, and you don't know what that is, okay? Don't panic, and you don't have to guess. Because even if I don't know exactly what it is, I can figure it out by test taking. Now, I want to say this again so that you understand. Content will always be better than test taking. So if you can know the content, that will always work better and you'll get a higher percentage right. When the content fails you and you don't remember it or you don't know it, then your test taking is going to kick in. Okay? All right, so I want you guys to look at this, and I want you to tell me what you would categorize on each side. This should be able to be split in the middle. What would you put on each side, and then we got to figure out which one we would pick. This is such a good test-taking one. I'm, like, really happy with it.
Such a good one. You're white? I was like, yes, girl.
Yes.
Yes. Muscle spasms.
Lord.
Yes.
All right, let's kind of figure this one out, shall we? Okay. If you know some things...
Jessica said tetany's the odd man out, I think.
Tetany is one of them that's odd man out. All right. So if we look at sodium of 147, that's high, right?
Yes, it is.
Potassium of 3.2, that's low.
That's low.
Do these not always go in an inverse relationship?
Seesaw, seesaw.
Okay, so we would put sodium here and potassium here.
Yes.
These are going to have to go together. Whether you choose it or you don't, those go together. Seizures. Where do seizures come from? High sodium.
Yes.
Because sodium, even though it is regulated by the kidney, it always has neuro side effects. So seizures are going to go here too.
They sure
Because
are.
if you've got high sodium, you're going to have the seizures.
Yes, yes.
Tetany. When do we get tetany? What electrolyte imbalance? Because it looks like we're going off electrolytes. Tetany is usually a calcium issue. I don't see anything over here on calcium, so this would go over on this side. Muscle spasms. Isn't that kind of sort of the same thing as tetany? So the muscle things are usually calcium. Calcium is regulated by the parathyroid, right? But we know that its signs and symptoms typically come in heart and muscle.
Yes.
So muscle spasms and tetany are going to go together. So you'd have to figure out, is this a sodium and potassium thing, or is this a calcium thing?
Yeah.
Okay? And so if I'm looking at this like muscle spasms, tetany, like usually these are abnormalities or low calcium. So this would probably mean it would be something with hypocalcemia.
Oh, that's what Jessica said.
Ah, okay. And this over here would be electrolyte imbalances of something, probably kidney, okay? So if I was looking at this, this would probably be something wrong with my parathyroid. This would probably be something wrong with my kidneys.
Yes.
So that will help to give me even further things in order to kind of figure it out, right? Yes. But if this is going to have sodium, potassium, and seizures, these all go together in such a perfect triangle that if I was going to have to choose between the two, because these are just two signs and symptoms, I'm going to choose the one that go together as the whole clinical picture. Patient's sodium goes high, their potassium is low, they're going to get seizure activity with it, okay? You can do this on almost every select all that apply. If you start to practice these and see, you'll see you can do this on almost every single one, okay? All right, any questions on those? All right, so today we have talked about what a nurse's role is in management. We have talked about what's delegatable, what's not delegatable, and we have talked about how to do priorities, including select all that apply questions. If you guys have any questions, post it on the page, we will have this one up for a good time, like probably a good 14 days or so. Okay.
Yeah.
So if y'all have questions or you want some practice questions, just let us know and we'll be able to post some and you can kind of synthesize what you've learned today. Okay. You guys did awesome today and we will see you again soon. Bye.
Be real, homies.